Hey everybody, we're gonna be starting in about 5 minutes here. So if you want to take a sec to grab a snack or something to write on, we'll be back in just 5 minutes. Okay, hi everybody. Thank you so much for joining us again. We're really excited. We have a super cool presenter today for you. If you guys will take a second to subscribe to our channel and stay up to date on our Instagram, we're going to be putting out a lot of later resources coming on our next sessions and all that kind of cool stuff. Here's some info about the quiz in case you guys were wondering.
Hi everybody.
Whoops.
Thank you so much.
So the link for the quiz will be sent out at the end of the session in the chat, and we'll have the link in our bio on Instagram as well. It's going to be open for 1 hour, and if you pass with 4 out of 5, you will get a certificate. And that should be emailed to you within about a week.
Cool. And if you guys will please just stay as active as you possibly like to in the chat. Ask all the questions, anything you have a question about, because your question could be something somebody else is wondering about, and Katie's going to be very active at answering those for you. We may do them at the end, or we may do them throughout, but just know that we're going to keep an eye. We're going to be writing them all down, and hopefully if you do ask a question, it will get asked to Katie directly. But yeah, guys, without further ado, here is Katie. Enjoy.
Can you guys hear me or see me?
Yep, you're perfect. We can see you. We can hear you.
Yeah, all right. Oh, awkward. Perfect. All right. Hi, guys. So I was like waiting. All I see is the black screen. Okay, sorry. I'm kind of new to Zoom, guys, so I'm kind of figuring out as I go. First of all, thank you for having me, and thanks for hopping on, guys. So I'm going to pull up the PowerPoint that I have on my computer. I'm going to share it with you guys. So give me 1 second to share my screen. All right, can you guys see that okay?
Oh,
Yep, everything looks perfect.
Perfect. All right, guys. So I have the YouTube channel pulled up. So if you guys have questions as we go about like the cases, please write them in the chat. I'll try and keep an eye on it. And if you have questions about like Navy stuff or like personal stuff about me, let's keep that towards the end because there's a whole section that I'm leaving open for questions. But if you have questions about any like the medicine or like stuff about the patient or treatment or anything like that, please ask as we go because that'll make the most sense. Everyone's very active in the chats. You guys picked a great PA to speak. She's amazing. Oh my gosh, that's so sweet. Thank you, Stephanie. Okay. All right. So let's get started. So briefly about me. So I was born and raised in Pittsburgh, Pennsylvania. So I'm in Chicago now. So not really too much of a change in weather. So we actually have like a 40-degree day here. So I'm used to this cold weather. So it doesn't bother me too much being in Great Lakes. I was actually accepted to a direct entry PA program, which a lot of people don't know a lot about. So way different than what a lot of you guys are doing in like this pre-PA world. So I applied when I was a junior in high school. I only applied to these 5-year programs. So you apply while you're still in high school, like you would for any 4-year university, and then you are accepted, and then you go the entire way through the program with your bachelor's, and then you get your master's right after. So I got my bachelor's in health sciences in 2014, and then you go straight through, you skip summers pretty much, and you start your professional phase, which is when you start your master's classes. So I got my master's about 2 years after that. And then decided I wanted to go into the Navy while I was still in PA school. I actually was interested in the Navy when I was still in high school. But the commissioning programs for the Navy for PAs, you have to wait until you're basically starting PA school to even apply for them. So the program that I did is called the Health Services Collegiate Program. And if you guys want to hear more about that, we can talk about that more at the end. HPSP, or the Health Professions Scholarship Program, that's the other big one for PAs. Also really big with like dentists and doctors too. Officer Development School is the program through the Navy that we go to basically to learn how to be like a Navy officer. So learning how to wear like military uniforms, how to salute, military customs. The program and the training that I went to, it's for what we call staff officers. So those are basically Navy officers that have jobs equal to like jobs in the civilian world. So like chaplains, lawyers, medical people. So your dentists, your doctors, your PAs, optometrists, pharmacists, all of the above. So my training wasn't like, I wasn't hiking through the woods, like with, you know, a whole huge ruck on my back. I wasn't getting like beat down too bad. They're pretty easy on us because we already have our commission. We're already officers when we go to this training. The Navy like selected us to go there. So they don't want to beat us down too hard. So really it's more academic based. So it's like how to be a Navy officer, how to lead junior sailors, other junior officers, those kinds of things. Got stationed at Naval Station Great Lakes, which is in North Chicago, Illinois. So I actually live in the suburbs of Chicago now and really enjoy the Windy City. I love Chicago. Orders for the Navy were kind of funny. I decided that I wanted to go somewhere warm for once. I picked all these cool duty stations. The Navy has some really cool duty stations. I picked like San Diego, Pensacola, Charleston, Corpus Christi, Texas, and I didn't get any of them. So kind of disappointed, but you kind of learn that's how it is. You want to go somewhere, but the Navy really has the ultimate say. And I'm okay with that. And I'm looking forward to like where I could go in the future. So a little more about me. I don't have any human children, but I have my fur children. So Argo is the one on the left, and then Maverick is the one on the right here, my German Shepherd. I just started this whole mentoring thing through my page with pre-PA and PA students, especially those interested in the Navy, because my route was a lot different than a lot of people applying through CASPA. I try to help the best I can with questions, but really like I focus mostly with my mentoring on like people interested in Navy medicine because it's kind of more what I'm an expert in. However, I have helped a local PA program over the last 3 years with like teaching, physical exam lab, interviewing like applicants and stuff. So I've gotten a little more of a taste of like CASPA and more about the application process. So I try to help people as best as I can, but I don't have personal experience with it quite as much. I used to enjoy working out at Orange Theory pre-pandemic, but we're not allowed to go to gyms anymore through the Navy. They're really strict with us with what we can and can't do. No like non-essential work. So got a Peloton. That's been my new workout regime. I try to do that daily. I really enjoy red wine. I like online shopping. That was even pre-pandemic. I always like online shopping. And then deep dish pizza. If anyone's ever been to Chicago, you know, we have the best deep dish, Lumanetti's. We get it like once every 2 weeks. We're obsessed with it. So. All right, so where I work now, so PAs usually in the Navy, we work in primary care. And the reasoning for that is because primary care allows us to be the most mobile throughout different areas in the military. So we can go work with like Marines, we can work in like a Navy hospital, an outpatient clinic to care for like other service members. So we work in primary care, urgent care type roles. There is a chance you could go to like an emergency room, work in like an emergency medicine type area. Unlikely. I have a friend who went to Okinawa, Japan, and she was in an ER. She did not complete a fellowship. That's where she went as a new grad. She loved it. She got really good experience, but that's kind of unlikely. So we really are based mostly in outpatient primary care clinics, caring for like service members. Rarely we would be caring for like dependents. That would be like spouses of the service member, and then also like their children, and then maybe occasionally veterans. But they're kind of starting to move us away from that, and they're getting us to focus more on like operational type medicine, which is like taking care of the service member and then taking care of them on like deployments and abroad and such. So there is an opportunity for us to specialize through the fellowships. There are 3 fellowships through the Navy that is in emergency medicine, orthopedics, and general surgery and critical care. So emergency medicine, you'll see that's a DSC. So what that means, that's a doctorate of science. So I don't know how familiar you guys are with these doctor of sciences degrees that are starting to come out a lot for PAs. Really, that's the way that a lot of PAs are doing their doctorates now, whether that be more like clinical based or like research based, so to go into more like academics. But the fellowship is obviously more clinic focused. The emergency medicine one is 18 months. The other 2 are 12 months. You have to apply for these, get selected through the Navy. The competitiveness of them kind of vary year to year, whether or not there's a lot of applicants. The emergency medicine was a little more, emergency medicine one was a little more competitive this year because the doctorate makes it a little more appealing to people because they get to have the degree out of that. And while you go through these programs, you're paid your normal salary, which is awesome because our pay after a few years of being in is very good. When you first come in, your pay is a little bit lower than what like your peers are likely making in the area. But as you've been in for a couple of years, your pay starts to go closer to like the national average for PAs. Someone asked how many MDs are there compared to PAs in the Navy. So there's a heck of a lot more physicians. I actually don't know the amounts. I can tell you that there are only like 340 active duty PAs in the Navy. So I call us unicorns. So there aren't really a whole lot of us. We have a very small, tight-knit community, and everyone kind of knows everyone, which I think is awesome. We have a Facebook group where people like ask questions and give tips and stuff. And it's like really nice to see us all come together. We had a, can you talk a little slower? Sorry. Okay. I talk fast normally. I'll try and slow myself down. So in the Navy, we have reserve and active duty PAs. So the reservists are the ones who will drill like 1 weekend a month, and they have like civilian jobs where they can work in whatever function or specialty they want to. And then they have a potential to be deployed, but the Navy isn't like their primary job. So there are a couple hundred reserve PAs. I'm not sure the exact amount, but only about 340 active duty PAs. If anyone has any questions about fellowships, please think about those. We can answer those at the end too. So upcoming for me, I'm really looking forward to a deployment to, can you change the playback speed to less than 1? I don't know if I know how to do that. Let me see.
I think that was just a recommendation for that person that was asking you to talk a little bit slower.
Okay. All right. I'll try to talk slower, guys. Sorry. I'm a fast talker to begin with. All right. So coming up for me, it was a joke. Sorry. So Africa, there is a base there, and there is 1 PA billet there. So this was a deployment that came up, and I volunteered for it. Super excited for the opportunity. So it's basically a base around Djibouti, Africa, where it's an operational standpoint for us to have, in case something happens, we have troops there. So there are US troops, there are international troops, British troops, Djiboutian troops there. So very excited for that. There's an emergency medicine physician along with a family med physician, handful of nurses, and a bunch of corpsmen. So very excited for that. I have a training that I'm leaving for shortly before that. And then I will head to Africa after. And I actually just found out, I don't know if any of you guys follow me on my page, but I just got accepted to the Emergency Medicine Fellowship in San Antonio, Texas. So super excited for that. It's going to be insanely difficult. It's going to be like going back to school, but it involves multiple different rotations through different areas that encompass emergency medicine. So radiology, anesthesia, trauma surgery, orthopedics, there's a pediatric ER, multiple different ER rotations. You have journal club. Basically the PA fellows are treated like second and third year emergency medicine residents. So it is like a huge undertaking and a lot of work, but very excited for it, excited for further training. And I'm excited to be a little more of an expert in a certain field. Sometimes it's hard being in primary care because you have to know so much, or you have to know a little bit about everything rather than just focusing in. And I do enjoy primary care, but I have always had an interest in emergency medicine. So super excited for the opportunity. There are 2 other Navy PAs going with me. I haven't really met them yet. I don't really know them, but my friend is actually the first Navy PA who's going through the doctorate program in San Antonio now. It used to be in San Diego. So very excited for that. And stay tuned for more. I will obviously post my journey as I go through. Obviously, not all these disclosures are my own, don't represent the US Navy. All right, so let's get started with cases. So please ask questions as we go. If you have any questions, I know a lot of people have different amounts of like healthcare experience. So I'm gonna try to simplify things. And if you already know that, good for you. If not, I'll try to explain as much as I can that isn't like common knowledge. All right, so chief complaint, that's what CC means. So it's a female wellness in processing visit. So what that means is this is a Navy recruit going through Great Lakes Navy base. All the female recruits that come in, they go through a questionnaire with us and they see our provider one-on-one on all things like women's health related. So like breast cancer screening, PAP screening, are they a smoker? What's their birth control? We advise them on Gardasil, the human papillomavirus, all that kind of stuff. So that's what female wellness in processing is, just FYI. So HPI, that's history of present illness. So this is basically further going into talking about the chief complaint. So this is a 19-year-old female seaman recruit here for female wellness in processing. She was found to be positive for chlamydia on her baseline labs. All the women are tested for gonorrhea and chlamydia when they first come into the Navy with us. On further questioning, she mentions a 4-month-long history of intermittent left lower quadrant pain. This has not been formally evaluated or treated previously. She describes it as a dull, achy type sensation, a 3 out of 10, that randomly will become more sharp and severe, like a 7 out of 10. The more intense pain occurs a few times each week, lasts a few hours, no provoking or relieving factors. She also endorses some abnormal vaginal discharge that is yellow in color, no foul odor that she's noticed. There's no genital pruritus or irritation. Pruritus is just itching. She denies any other associated symptoms, including nausea, vomiting, fever, chills, dysuria, that's pain when you pee, hematuria, which is blood in the urine, an increase in urinary frequency, hesitancy, flank pain, that's just pain over here where your kidneys are, diarrhea, constipation, or blood in the stool. Last menstrual period was about 3 weeks ago, and she was last sexually active about 2 months ago, unprotected penetrative intercourse. So it's a little more about her. She has no significant past medical history. She's very healthy otherwise. She's not on any current prescription medications. Her vitals are normal. So pertinent exam findings. So pertinent really means like things that we care about. So general, she's a well-developed, well-nourished young female and no acute distress or pain. She's pleasant to talk to. Her heart, so RRR means regular rate and rhythm, no murmurs, rubs, or gallop. So basically this is like abnormal heart sounds. Her lungs are clear to auscultation bilaterally. Her belly exam shows that she is diffusely tender in all 4 quadrants. So that basically means right upper, left upper, right lower, left lower. So that's what times 4 means. She is most tender in her left and right lower quadrants. She doesn't have any rebound or guarding. So rebound or guarding are important when you're basically trying to determine if someone has maybe like a surgical cause of their pain. So the rebound or guarding could be seen if someone has like an appendicitis, if they have something called like diverticulitis, like an infection brewing pretty much, because the rebound or guarding, that's basically a sign there's an infection in there, something acute. And that basically means that person needs like a higher echelon of care, like a CT scan, more labs, like an inpatient type evaluation, more than just you would keep someone in an outpatient clinic for. So if someone has like rebound or guarding on their exam when I'm seeing them in an outpatient clinic, I know there might be something going on and I can't just kind of like push it to the side and like have them follow up. It usually means maybe going to the ER or like an inpatient admission after that. She has a negative Rovsing and McBurney. So Rovsing is basically like a special test in the belly where you would press in the left lower quadrant, and that would produce pain in the right lower quadrant. That is a sign for appendicitis. So if someone has pain when you press in their left lower quadrant and it radiates to the right side, and the patient says, yeah, that hurts in my right lower side, that's a positive Robsang sign. So you're concerned about appendicitis if someone has that. McBurney sign is basically the point right where the appendix is. And I'm like looking at myself, trying to point at myself. So McBurney is basically the point where the appendix is. So that's right between the belly button and the top of the hip bone. So it's kind of like if you draw a diagonal line like this, it's like right in the middle here. So if you press there and someone has pain, that's a positive McBurney's point sign. So that's another sign for appendicitis. So if you press there and they say, yeah, that hurts, you would say positive McBurney sign. She has no CVA tenderness. That's costovertebral angle tenderness. So that's basically pain over your kidneys or flank pain. So you do that by taking your fist, putting it on the back, and then you whack your fist against the person, and they would say like, ow, that hurts. It's kind of like not the most comfortable thing in the world, but people who have true CVA tenderness, they like jump or they'll be like, ouch. Sometimes people think I'm like beating them, but it's just like the test you do. Her genital exam and her pelvic exam. So it showed thin white discharge coating her vaginal mucosa. So that's basically like the tunnel leading to the uterus, which is the bottom portion where the cervix is. And we have a picture of that later. She does have cervical motion, uterine and left adnexal tenderness. So basically what that means is whenever you're doing a pelvic exam, you learn about this in PA school in your history and physical exam class. There's something called a bimanual exam, which is where the examiner will use their hand intravaginally and then one hand on top of the belly. So you're basically doing both at the same time simultaneously. Cervical motion tenderness is whenever you use two of your fingers basically to move the cervix and manipulate it side to side. So when you do that, you're basically moving the peritoneum, which is like the connective tissue inside the abdomen, and you're bouncing it around. So if you do that and someone has inflammation or like infection there and they say it hurts, that's like a concerning sign for like peritoneal irritation or like something we're going to talk about called pelvic inflammatory disease. So whenever I moved her cervix, she said, ow, it hurt. She actually had tears in her eyes. It was bothering her a lot, which is definitely like a positive for cervical motion tenderness. Her uterus was tender, and then she had left adnexal tenderness. The adnexa is basically just an all-encompassing term for like the ovaries and the fallopian tubes. So whenever we feel on like the left side of the patient, she had pain on that side when I was pressing down and using my hand to feel her ovary and her fallopian tube. So pretty painful pelvic exam. Anytime a female has like cervical motion, uterine or adnexal tenderness, you have to be like concerned for something. And this is like one of the reasons why that's part of the exam, because PID is like a can't miss diagnosis. Because she had the abnormal vaginal discharge, I took a wet prep. A wet prep is basically just a lab sample that's a culture of the discharge. And it looks for like yeast infection, something called bacterial vaginosis, and then a sexually transmitted infection called trichomonas. So I got that because the discharge looked excessive to me and not like your normal discharge. All women have like a normal physiologic discharge, which will change based off of like the time of the month and where they are in their cycle. So after doing a bunch of pelvic exams, you just kind of get an idea of like what's normal and what's abnormal. So she had a little more than what I would usually see for like a physiologic discharge. So I took a sample of that. Okay, so diagnosis, pelvic inflammatory disease, and we're going to talk about that. So I'm going to actually skip to the next slide and we'll go back. Okay, so a little bit about PID. Please ask questions as we go if you have them. I'm looking at the YouTube chat right now. So what's PID, pelvic inflammatory disease? So this is basically an acute infection of the upper genital tract in women. And really it can affect all or like one of the following. So that would be your uterus. So that's right here, your fallopian tubes, which are these things right here on either side, and then the ovaries, which are right here. So it can affect all of them or just one of them. Does anyone know what the most common cause of pelvic inflammatory disease is? You can answer it in the chat and then we'll talk about it. I'll give you guys like a second to collect your thoughts. Most common cause of pelvic inflammatory disease. And if no one says anything, that's okay. I will just tell you guys anyway. No one's really sure. That's okay. That's why we're doing this, right? Okay, so most common cause of pelvic inflammatory disease is actually sexually transmitted infection. So like your gonorrhea, I'm saying now STD. Yeah, very good guys. Okay, they didn't pop up until now. They told me there was going to be a delay and I actually forgot. So sorry guys, they told me about that and I should have given you more time. A lot of people got it. Awesome. Okay, good job, guys. Cool. So STD or STI, you'll actually hear STI more nowadays. STD is actually kind of like being pushed aside as being not like the most politically correct term to use. So now we mostly use like STI, sexually transmitted infection in medicine. You'll learn that probably more in school. So about 85% of cases of PID are caused by sexually transmitted infections. So small percentage, so around 15% are caused by more like enterobacteria, so that would be like your E. coli, or even like respiratory pathogens, so like your strep pneumo, or like a staph aureus. So most common in childbearing aged women, so women who are sexually active, maybe have multiple partners, unprotected intercourse. Those are all risk factors for pelvic inflammatory disease. PID is a clinical diagnosis. And what that means is there's no gold standard test, which you don't hear about that a lot in medicine. There's always a gold standard. That's a big boards question for PAs and physicians on boards, is what's the gold standard test for it? So it's basically treated based off of the patient's symptoms. So if someone has lower belly pain, they have a positive STI screening especially, and they have the hallmark signs. So that would be like your uterine tenderness, cervical motion tenderness, lower belly pain right here, you treat them for PID. And the reasoning for that is because there is a huge risk of infertility problems later in life, because it can cause tubal scarring in the uterus and make it more difficult to get pregnant. So the possible long-term side effects are too bad to just push it aside and say they probably don't have that. So if you suspected it at all as a clinician, you treat them. So this girl was almost like a picture perfect patient, except for the fact that it's been going on for so long. Most people with PID, their abdominal pain is more acute, so a couple of days to a couple of weeks, but hers was a little more indolent, only bothered her for 4 months. So, and it wasn't really too bad. She never really did anything about it. Hallmark signs we already talked about. So a big pearl that I want to give is people always forget about ectopic pregnancies. So an ectopic pregnancy is basically a pregnancy that is not where it's supposed to be. Most commonly it's in the fallopian tube. So that's right over here. So instead of being in the uterus, it's over here. And we care about that because an ectopic has a chance of rupturing. That's a non-viable pregnancy. It cannot be carried to term. So if it ruptures, that's bad. That's very unlikely, but it's bad because if it happens, it does require surgery, and it can cause like internal bleeding at that point. So this is one of those can't miss diagnoses. So whenever you're in like an ER, or even like an outpatient type setting, and a woman is complaining of lower abdominal pain and she has any chance of being pregnant, meaning she's of childbearing age, you want to get a pregnancy test. So for this patient, didn't really have to because she just had a pregnancy test a day ago for her in-processing labs, and she was last sexually active about 2 months ago, and her last menstrual period is 3 months ago. Now, patients do lie. That happens a lot. So even if she told me that, I still would have gotten a pregnancy test because if I missed that, not good. So don't want to miss an ectopic pregnancy. So we're going to go back for a sec. Oh, maybe not. All right. So that's a little bit about PID. If anyone has questions about PID, please drop them in the box and I can answer them as we go. DDX, so that's differential diagnoses. We already talked about ectopic. So differentials are basically like, what else could this have been? Ovarian cysts are usually benign. They're nothing you really have to worry about unless it's a bloody one, like a hemorrhagic cyst, in which case it could cause like some blood loss if it's really, really big. That's really unlikely. Ovarian cysts usually cause like abrupt lower abdominal pain in women that is bad for a couple of days, but then gets better with time. It's just treated symptomatically. So usually with like NSAIDs, so like your ibuprofen or even like a Tylenol, you're not really too worried about them. And because her symptoms have been going on for so long, I wasn't really worried about that. Ovarian torsion, this is a diagnosis that scares me. I'm scared of missing it. So because the signs can mean so many other things, like an appendicitis, ovarian torsion is basically whenever this rotates on itself and it twists, and that can cause like necrosis of the reproductive organs and not good things. So basically young woman with terrible onset lower abdominal pain, like unconsolable, you can barely talk to them. That's like concerning for ovarian torsion. Endometriosis is really like small samples of uterine tissue are places they're not supposed to be. So hallmark sign of endometriosis is really, really painful periods every month. So this also usually runs in the family. So if you have a patient who says, my mom has endometriosis, my aunt, my grandma, and they have miserable periods, very likely they have endometriosis. So this isn't like an acute type thing. It's like a chronic thing, and it happens monthly and it's cyclic usually. So meaning it happens like with their period around the same time every month. So it didn't really fit the picture of this female that we had. Cystitis is just a urinary tract infection that sometimes can cause like lower belly pain, but she has no urinary symptoms whatsoever, so unlikely. Appendicitis, hallmarks of that, nausea, vomiting, fever, right lower quadrant pain. So it doesn't really quite fit her picture. So these are other ones to consider. And patients, we say they don't always read the book on diseases. So that means that patients can present with symptoms that don't really match the textbook definition, and it actually is that diagnosis. So you always have to keep other things in mind, but I just kind of wanted to run through these so that you guys know like my thought process and other things that you can kind of think about whenever you're trying to diagnose a patient. So treatment for her. So the treatment for pelvic inflammatory disease may vary if they are unstable, or if they have immunosuppression, or if they're not responding to medication they've already been treated for PID with. So say she was treated for PID 2 weeks ago, and now she comes to me and she has like a fever, she's vomiting, her belly pain's getting worse. She's going to be an inpatient. So she's not going to be able to be treated on an outpatient basis anymore because she's not responding to medication. Overall, she's hemodynamically stable. Her vitals are fine. She's not hypotensive. Hypotensive means she has low blood pressure. Her heart rate is good. She was tender on exam, but she's overall comfortable and stable. So there's no reason to send her to the hospital. A lot of times PID can be managed as an outpatient. So treatment for PID, and this is recommended by the CDC. The CDC has awesome guidelines for STI treatment. So if you go online and just type in like STI CDC, it'll pop up on Google and it'll give you like a whole breakdown of guidelines for treatment. So if someone's allergic to this, what do you give them? If this is second line, if they don't respond to this. So it's a really easy breakdown, and it's good for like students and when you're on clinical rotations too. So what we treat her with ceftriaxone. So this is a 1 dose of an intramuscular injection. So we gave her that. She got that in her buttock. Doxycycline. She got this twice daily for 14 days. So it's kind of a longer course of antibiotics. There are a lot of things to know about doxycycline. I don't know if anyone's ever taken it before or what you remember about it, but things to know about doxy that you want to educate patients on. So it is very likely to cause gastric upset and vomiting. If you don't eat it, if you don't take it with food, you will very likely throw up. And I can speak from personal experience. I was on doxycycline when I was in my undergrad years. I had terrible, terrible acne. I was on it for 6 months, and I saw the most wonderful derm PA, and she had me on topical regimen, including oral doxy twice daily, this exact dose actually. And she said, Katie, make sure you have like a hearty breakfast with it. I told her I usually didn't eat breakfast. I was never hungry in the morning. And she said, you will throw up if you take this on an empty stomach. And I said, yeah, right. Went home the next day, took it on an empty stomach, puked my guts out. So I learned my lesson, never did that again. I felt miserable. So now I'm very like good with teaching patients about this. And I say, this happened to me. Don't let this happen to you. So want to have something hearty in your stomach, not like one bite of a granola bar. You need to have like, half a bagel, piece of toast, like a supple, like protein bar, something good. Photosensitivity. So this just means, more likely to hurt your eyes in the sunlight. It can also make you more likely to get like sunburn. Doxy sounds brutal. Yeah, it works really well though. So it worked really well for acne. So as long as you take it correctly, it's fine. Esophagitis, that's just basically inflammation of the esophagus. So you want to make sure you tell patients, take it with like a glass of water, and don't take it right before bed whenever you're going to be laying down. If you take it right when you are about to go to bed, when you lay down, it's more likely it's going to regurge through the stomach and the esophagus and irritate the esophagus. And that can be like really painful and take a long time to recuperate. So you want to warn patients about that. A lot of patients, sometimes they'll swallow pills without like water if they're like lazy or if they just don't feel like taking it with a glass of water. So you say, take it with a full glass. It can irritate your esophagus if you don't. In addition to the doxy, she got metronidazole, 500 milligrams twice daily for 2 weeks also. So remember the wet prep we did during the pelvic exam? So it actually showed something called bacterial vaginosis, which is not necessarily sexually transmitted. It can just happen. It's basically an alteration in the vaginal flora, but it can cause like abnormal discharge, foul odor, itchiness, genital irritation, that kind of stuff. So because bacterial vaginosis can be a cause of pelvic inflammatory disease, you want to test for it and treat for it. So we're treating her for 14 days with the metronidazole as well. So she's got a lot of medications to leave with. We talked about PID. So after I educated her on that, gave her strict instructions to come back and see me in 2 weeks. She should come see me sooner if she was feeling worse in any way, if she started throwing up, she started feeling feverish. If it was outside of working hours, so I work like Monday through Friday, 6:30 to like 3 or so, then she should go to the ER. With PID, you want to make sure they follow up. Patients a lot of times can be lost to follow up. So what that means is they see a provider, they take a medication, they think they're better, they don't go in for a follow-up. Or say a patient doesn't have health insurance, they go to an ER or an urgent care, and they always put on those discharge instructions, follow up with your PCM in like 7 to 10 days. And patients don't do that. So it's super important to follow up if someone is suspected to have PID, because you want to make sure it's getting better, because if it doesn't, it can cause those fertility problems later in life. So definitely important to have the patient follow up after and emphasize the importance of that. Because this was at Navy boot camp, it's a little easier to like have, to account for people. So I wrote her name down. So if she didn't come back and see me, I was going to like recall her anyway. So, at her follow-up visit, she was doing a lot better. Her abdominal pain that she had for several months was gone. Her exam was repeated. She had no belly tenderness. Before, she was tender all over, mostly in her lower belly, and she had no tenderness at all. And then we repeated her pelvic exam, and everything was normal. She had no cervical motion tenderness, no uterine, no adnexal tenderness like she had before. So that's awesome, and I call that a win. So she had a resolution in her symptoms. She was treated successfully. I did remind her to notify her previous partners of her positive chlamydia results so that they can get tested and treated as well. This kind of varies provider to provider with what you do. But if I have a patient who comes in and says, I have a partner who I was recently sexually active with, they tested positive for gonorrhea or chlamydia, I would treat them regardless of what their test results were, because there is always a chance of like a false negative. So if they said I had unprotected penetrative intercourse with someone and they tested positive for chlamydia when they went to like a Planned Parenthood, I would treat them for that. Some people have questions here. The more general questions we'll save until the end. Before diagnosing a patient, what are the general thoughts you have to diagnose a patient, then treat the patient with the medication if needed? So this gets easier as you go, but really it's like you run through a differential list in your head. So it's like, okay, it's most likely this, but what else could it be? And then you need to think about covering your bases. So it's like, what else do I need to do to roll out those other diagnoses? And then those can't miss diagnoses, which are those things that are like potentially life-threatening. So like the ectopic pregnancy, we knew she didn't have that because she had a negative pregnancy test and she had a period 3 weeks ago and her last sexual intercourse was 2 months ago. So you kind of just running through the basics of that, covering your differentials. And then if I don't know a treatment plan right off my head, I can either talk to one of my collaborating physicians, another PA, another NP, to bounce ideas off of them, or you can always look it up. There's great resources online. I love UpToDate. I use that a couple times a week at least if I'm not sure about a treatment or like a dosing for something. PID, I treat someone frequently, so I actually know their treatment off of that, kind of like off the top of my head. Someone says, how does recall work? Sounds great for increasing adherence. So it's a little bit different in Navy world and in boot camp world. So they kind of like have to follow up if we tell them to, because they have these things called hard cards, and we'll say like seaman recruit so-and-so to return to medical on this day. And the people who are in charge of them see that and they send them back. So if only the civilian world worked that way, patients would have way better follow-up because it almost forces them to come in. But you know, you have free will in the civilian world, where in Navy lands, if someone has a follow-up with medical, they pretty much have to do it, because if they don't get cleared by medical, they can't complete training and like graduate and go into their further trainings and duty stations. So yearly testing for STIs is still recommended by the CDC. So a lot of women and men don't know that. So especially if you are sexually active with multiple partners, unprotected intercourse, you should get yearly STI screening. Does the Navy pay for an upstate subscription? Yeah, the Navy actually has one, so I don't have to pay for it. It's just through work. So I go online and I can access the site, and I can actually access it from home as well with my login. So it's really nice. I use it to study as well. All right. Any other questions about case number 1, pelvic inflammatory disease, treatment, STI, anything about it? I'll give you guys like a minute or so, because I know there's a lag. And then we'll move on to our second case. And I put on 2 cases for you guys because I wanted to leave time for questions and I didn't want to bore you too much. This is our last one, but kind of a different realm of treatment and body system for what's going on with this kid. We'll see next. So the cause of the PID is chlamydia, and both are treated successfully. Yes. So we had the luxury of having her STI results when I saw her. They get all of their labs when they first come in. And then by the time they see us, we have their STI results and their pregnancy test results. So I already knew she was chlamydia positive. And then when she came into my office and she started talking about this abdominal pain, first thing that came into my head was PID. So positive chlamydia or gonorrhea and belly pain, it's PID until proven otherwise. And then her exam findings with the uterine and the cervical motion tenderness just confirmed my diagnosis. Could you explain what UpToDate is? So UpToDate is basically like an online database. It's like the best one in my opinion. A lot of universities and like, I guarantee almost like every PA school has it. A lot of health systems have it as well. So you can go on and you can search like any sort of term, medication, and it gives you a breakdown, and it's listed in like a really easy to understand way. And it's easy to maneuver it. So say I type in like pelvic inflammatory disease, it'll say like differentials, treatment, outpatient versus like inpatient, things to consider, clinical manifestation. So it basically runs you through the entire thing. So I use it a lot to study for in PA school. It was actually what I pretty much exclusively use on rotations if I had a question about something and didn't want to ask my preceptor because I was scared. I use it like in practice all the time. And it's like our favorite at work too. A lot of other clinicians like to use it as well. Are there an equal number of male, female Navy PAs? Can the people you treat pick who they want to see, like gender wise? So they asked if there are the same amount of male and female PAs. I think we're male dominated in the military, which is interesting because in the civilian world, we are definitely more female heavy. And a lot of times patients can have a preference in who they want to see. But unfortunately, sometimes if you're on a ship somewhere and there's one medical provider and they're a male or they're a female, sometimes you got to like take what you can get. So in a clinical like setting, like a outpatient clinic, there are usually multiple providers. So if a patient wants to see one gender versus the other, we try to accommodate that. We would never tell them no. But if you're in the middle of a desert in Afghanistan and you have a male PA and he's the only one who can do a pelvic exam, you don't really have much of a choice, but you always have a right to refuse medical care. But yeah. All right, so we're gonna move on to our next case. So this is chief complaint of cough times 5 days. History of present illness. This is an 18-year-old male, also seaman recruit, so he was in boot camp as well, and he had a cough for 5 days. It is productive and has been keeping him up at night. He does endorse some shortness of breath with activity, like running and going up the stairs. He has no fever, chills, or chest pain. He has not tried anything for his symptoms. He denies any other associated symptoms, including congestion, headache, sore throat, myalgias, which is muscle aches, or ear pain. Put a little disclaimer at the bottom. I said this case was about 1 year ago, BC, before COVID. So COVID is not on our differential. We're not worried about COVID. This was like early 2018. All right. So more about this kid. He has no significant past medical history. He's very healthy. He's not on any prescription medications. His vitals, his oxygen is 96%. His heart rate is 118, blood pressure 122/86, temp is 101.4 degrees Fahrenheit. What do you guys think about those vitals? I'll give you guys a second to answer. I learned my lesson. I forgot there was a lag, so I'll give you guys some time. So what do you think about the vitals? Are they normal? Are they not normal? What are you worried about? Good, we're getting some answers here. High heart rate. So what's normal heart rate? What's the high end of normal? Someone said tachycardic. That's good. Tachycardia is the medical term for fast heart rate. So tachy means fast. So tachypnea means like fast breathing. 70-ish, good. So 70-ish, 70 beats per minute is actually like right around middle of the range. So high end of normal we say is 100, but young, healthy men and women, like this population we see in the military, they shouldn't really be higher than usually like mid 90s. So if someone's like 99, I'd probably retake it because I'm like, that just seems a little high for a young, healthy person. 60 to 100 is normal. Awesome. Yeah, you guys are good. Fever, maybe an infection. Awesome. Good job. What about an SpO2 of 96? Are we worried about that? SpO2 means oxygen level. So that's like when you put the pulse ox on their finger and it reads at 96. Kind of low, someone said. So our like, I need to be a little more worried about this type level is like 94. So 96 is like definitely a little like, is there something going on here? I'd probably tell the person to take a couple of deep breaths after that. And I did that with him and his didn't go above a 96. He actually fluctuated between like 95, 96. After a couple of deep breaths, he still hung right around there. So heart rate 118, definitely high. We're worried about something going on here like acutely, or is that like where he normally hangs at? And you usually want to ask a patient, like, does your heart rate usually higher, or do you get nervous in like a medical type setting? Because that's something that can fluctuate so much depending on patients. If they get really nervous, they get what we call white coat syndrome. That means they could like go up as they're in a clinical setting, or their blood pressure could go up in a clinical setting. That happens a lot with people who are a little more anxious or nervous about being like in a medical clinic. And then obviously temperature. So there's some like conflicting evidence with what is like a true temperature, but really anything above 100.4 is considered an elevated temperature, so a fever. So you can say this person is febrile. So febrile means they have a fever. Afebrile means they do not have a fever. Good job on those questions. We'll keep asking questions as we go because I think it makes it a little more fun. I don't like just talking to you guys, I like seeing what you guys are saying back. Pertinent exam findings. So what do we find on his physical exam? So he is a well-developed, well-nourished young male. He's in no acute distress, but he does appear kind of pale and just fatigued. And as you get on rotations and you practice, you kind of get this like eerie type feeling when a patient is like sick just by looking at them. Patients can like say they don't feel well, but when you walk into a room and you look at someone, you're like, this person is sick. That's kind of like when you have something going off in the back of your head. Like, I need to be a little more concerned about this patient because there's something like definitely going on with them. So when I first saw him, he just didn't look good. His heart exam, so he was tachycardic. He had a regular rhythm. So what is the difference between like rates and rhythm? So if I say someone has an abnormal rate, which he does because he's tachycardic, but a regular rhythm, what does that mean? What's the difference between rate and rhythm? Someone said I'm learning so much. Yay, that makes me so happy. This is so fun. I love teaching in my clinic. My corpsmen, PAs came from Navy corpsmen, so it's like giving back to the corpsmen, teaching them, mentoring them. So I love doing this with you guys. It's super fun. Difference between rate and rhythm, because there's a big difference. How consistent it is. I think I know what you're saying there. Rate is the speed of heartbeats. Rhythm is the regularity of spacing between heartbeats. Exactly. Madeline Payne hit it the nail on the head. So very good job, Madeline. So that's the difference. So rate is like the numbers. You can think of rate as being like 70 beats per minute, 80 beats per minute. His was 118 beats per minute. But his rhythm is regular. So what that means is he's tachycardic, so his heart is beating fast, but the time between the beats is the same. So say someone's heartbeat is going boop, 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 boop. That's an irregular rhythm. So there's not the same amount of time in between each heartbeat. So that's like a true, like concerning arrhythmia usually. So he is tachycardic, his heart is beating fast, but it is regularly irregular. And that's a term I'm not going to get into. So, but his heart is beating fast and there is the same time in between beats. So that's what that means. No murmurs, rubs, or gallops. So rubs is like pericardial friction rub is really the big thing with that. So that's whenever the pericardium is inflamed, that's the outer layer of the heart. So if someone has like a pericarditis, you could actually hear a shh, 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 shh when the heart is beating. So that's what that R means, rub usually. Gallop is pretty much like an extra heartbeat. So that would be, it's called like an S3 or an S4. We're not going to get into that now, but that's what MRG is. That's pretty much standard. You'll see that in medical documentation. So his lung exam, pretty abnormal. So decreased breath sounds throughout all lung fields. It was difficult to appreciate any adventitious sounds. So adventitious sounds basically means sounds that are not supposed to be there. So that can mean like a wheeze, a ronchi, crackles. So really everything seemed really far away when I was listening to him. And this was the first time I heard anything like this. When I was practicing, I heard someone I was on rotation, some like scary sounding lungs when I was in like an ICU. But this was the first like patient of mine that I had where I heard something like this. So all of his lung sounds sounded super far away. I actually had to double check my stethoscope to make sure I had it like turned the right way because I really could barely hear anything. I did like an ear, nose, and throat exam. That's what ENT means because he has like a cough. So usually you'll learn how to tailor your physical exam based off of a patient's presentation. So I did like look at his ears and his throat and everything looked fine. His TM is tympanic membrane. So that's your eardrum. It was pearly, which is what you want. He didn't have any redness or bulging in his eardrums. His oral pharynx, so the back of his throat was clear. Tonsils are 2+, which is normal. He had no lymphadenopathy, that's swelling of the lymph nodes, and he had no tenderness in his lymph nodes as well. So after I heard his lung sounds and saw his vitals, that kid went straight to radiology. We do have a radiology tech in our clinic, and we can order like orthopedic x-rays, chest x-rays, abdominal x-rays, so it's super nice and convenient. Someone said, what do you mean by pearly? Sorry. So if you actually Google like normal tympanic membrane or normal eardrum, you'll see that most of the pictures, the light is like shining back at you. So pearly means that it's like nice and clean and it's not red. Sometimes we'll use the term boggy. That means it's kind of like cloudy or like dull. And if someone has like an angry eardrum, like they have an ear infection, it'll just look really red and they won't have that nice pink pearly look to it. So that's like a normal eardrum is when it's pearly. And you'll see that in documentation. So sent him to get a chest x-ray and sent him to get some labs, so a CBC. Who knows what a CBC is? Can you guys tell me what a CBC is and what it's like helpful for? Why you would want to order one, what you can see on it? Good question so far, guys. Thank you for asking me to clarify things. Complete blood count. Good. So what can you use a CBC to help you with in terms of like diagnosing someone? WBC, so good. Ellie said WBC, good job. Complete blood count. Yeah, very good, guys. Awesome. So big things on the complete blood count. So your white blood cells you're looking at and your red blood cells. So if you're looking for anemia, so someone has like less red blood cells than they're supposed to, or if someone is like iron deficient, you could see that on a CBC. And then if someone has an infection, their white blood cell count will be high. A lot of more answers coming in. Good job. A lot of guys know what that is. Awesome. All right. So moving on. Oh, we're going to look at chest x-rays first. I forgot. Sorry. Okay. Because we ordered one and I wanted to look at it because it's kind of like a cool thing to learn about. Chest x-rays are super fun. They're also really difficult. Chest x-rays are something that I feel more comfortable with now, more comfortable than like orthopedic x-rays personally. So abdominal and chest x-rays, I feel somewhat okay with. But like if someone falls under their wrist and we're looking for like a fracture in the small like hand bones or the wrist, like I don't feel 100% confident in my skill. That's why we have radiologists and collaborating physicians as PAs. So I'll grab one of them and say, hey, take a second look at this x-ray with me. So briefly about chest x-rays, they're really useful. They're cheap and they're easy to do in an outpatient setting. So they can be used in primary care clinics like where I was, or like an urgent care, ERs, in a trauma scenario, someone's in like a car accident, and in like ICUs. So a lot of times in outpatient and inpatient, they can be used to track a patient's response to treatment. So say someone had like a really nasty pneumonia and like they're kind of feeling better, but like they can't really explain to you how they're feeling. You could always repeat a chest x-ray after they've been on a medication, like an antibiotic for a pneumonia, to see if on imaging, if their pneumonia is truly improving. In an ICU type setting, that's really common. These patients get like daily chest x-rays, and ICU residents and like attendings will sit and they'll do like chest x-ray rounds, and you literally look at a person's chest x-ray over like 7 days. That's super common in like the critical care setting. Okay, so how do we look at chest x-ray and how do we know what's what? So if you're looking at it, this is a pretty good example of a normal chest x-ray. Your bone is going to absorb more radiation. So that's going to be more white, okay? So that's what these bones are right here. Air will appear more black. Obviously, our lungs have air. If they don't, that's a problem. So that's why these lung fields right here are more black. Fluid, so if someone has like a pneumonia or some sort of effusion, that'll appear more white. So that's one big thing that is usually easy to see on chest x-ray. We're just keeping it really broad here. I'm not going anything crazy because I'm not trying to confuse you guys. But if you have any questions about what we're touching on, please feel free to ask them on chest x-rays. There are a bunch of different methods in terms of how to read chest x-rays. One commonly used one is the ABCDE method. So this is basically like a methodical approach to reading. There are different ones. This is one that I was taught in school and I liked it. This is actually how a lot of ER docs that I worked with on rotations read chest x-rays, because a lot of people, when they're first getting into practice, you get a chest x-ray and you just want to look straight at the lung fields, and you're not supposed to do that. There's so many other things that you look for on chest x-rays. So we start with A. So A is your airway. So to orient you here, so this is these are your spine, your vertebra right here. So A is your trachea. So that's this thing going right down the middle here. Then you also see right here, the right and left main bronchi. So right, left. B is your bones. So that is your like shoulder, your spine we already talked about, and then your ribs. So you can actually see both sets of ribs, so the front and the back on your x-ray. So to help you remember in school, I always thought horizontal, posterior, HP, like an HP computer. I don't know why that stuck with me. It just did. And to this day, it's like how I remember it. So the bones that appear more like horizontal, so that's like these ones right here, those are your posterior bones. The ones that appear more vertical like this, those are your anterior. And this film is actually over-penetrated compared to our last one. So if you'll see this one, you can see the ribs really clearly. So let's look at this one. So this is your posterior, 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 and then anterior, anterior, anterior. Okay. Over-penetrated is just like kind of the tech's fault, to be honest. Usually this isn't the best picture for it, but I just wanted to show you guys this ABCDE method, and I like this picture. So because it's super black here and you can't really see the ribs, that's a sign this film isn't like the best film. So ignore that for now, but that's how I remember like which ribs are front, which ones are back. I'm sorry, anterior means the front, posterior means the back. Sorry, I didn't clarify that. Cardiac for C, so looking at the heart. So chest x-ray, a lot of times is the first thing that we do to find these incidental things. So you could look at a chest x-ray for someone who's having like dyspnea or difficulty breathing, and their heart on chest x-ray is huge. And then that leads into this huge workup for other things, like an echocardiogram. They're going to get like stress testing done. So this is a cheap thing that you can do in an easy setting to look for things like that. So silhouette sign I have right here. So silhouette sign is basically whenever the borders of the heart are not clear. So if you see like fluid here, or you can't really see these angles clearly, that's a positive silhouette sign. That's concerning for like maybe like a pleural effusion or like a pneumonia. And then also for size, so really normal size is this heart should be less than half of the transverse diameter of the x-ray. So if someone's heart is more than double the size of going from here to here, that heart is too big. And radiologists can like measure it, and they have all these tools and stuff, like that's well above like my head. But if you do a quick like look at it, the heart should be no bigger than half the size of basically like your screen at the lung field. Diaphragm. So this is right down here. Diaphragm is the muscle that lets us breathe. You'll see the right side is slightly higher than the left. That's normal. That's because we have this big chunky organ over here called the liver. So that's pushing the diaphragm up. So this is normal. This X-ray doesn't have it, but sometimes you'll see what's called the gastric air bubble. So that's the air that is inside the stomach, and that's a normal finding. So if you see a black pocket here and you're like, whoa, why is there air there? That's not good. That's a normal finding. Don't be worried about that. But we are always concerned about air that is like right underneath the diaphragm. Usually that means like something went not right, and like a surgery, or someone had a perforated ulcer in their stomach that led to like an opening of an organ that allowed air to get somewhere it's not supposed to be. So that's concerning. That's like a surgical emergency. That's a can't miss diagnosis. This cardiophrenic, costophrenic angle. So if you see what's called blurring of these angles, that would mean like this right here should be nice and sharp. So if this is like kind of white and hazy and you can't really see this sharp angle here, that's concerning for like a pleural effusion or like an ammonia or fluid accumulation. So cardiophrenic, phrenic means like diaphragm. So cardiophrenic would mean blurring of this angle here. And then costophrenic, so that would mean like diaphragm with these like ribs right here. So this is a nice sharp angle, and that is normal, okay? And then everything else is E. So basically your lungs, because that's like the most important thing that we haven't really talked about yet. So this is like comparing side to side. So looking at your right, looking at your left, and looking at a chest x-ray. I'm sorry, I didn't clarify this to begin with. So this is like you're looking directly at the patient. So this is their, whoops. So this is their right side, this is their left side. So look at the right lung field, look at the left, look at the right, look at the left, and you're comparing for equal translucency. So that's like, is there more black over here versus white? If you see haziness on one side and on the other, then you're like, maybe that's a hazy, like patchy pneumonia. And in practice, it kind of depends where you are. If you have a radiologist who does these reads for you, it's super nice because you can like compare your review compared to them. But if you don't, and you have to do it yourself, then you really need to like get a little more practice in and try to make sure you're confident in these skills. So a lot of times I'll go look at the chest x-ray myself and be like, oh, I think it looks fine. And then I'll get the read back like an hour later. And if they show something or they have something that I didn't see on the x-ray and I let the patient go and it's something like not really concerning, I'll bring them back and say, hey, the radiologist found this like small cyst there. Like, we're not worried about it. But a lot of times the radiologist, they have the final say, but they're the experts. They do way more training than we do to like study these things. So that's briefly about how to read. I hope that's helpful. If anyone has any questions, like later, if you think about it, go back to it, feel free to answer. But this is a common method they teach in like school and in practice. So, all right. So moving on from chest x-ray. So this is not his x-ray. I didn't have like permission to use the image, so I had to find one online. But this is kind of what it looked like. So what do you guys think about this? I just realized I have the answer right here. Never mind. So this is pretty much what his looked like, except that he had a little more, what I said, white haziness. So a little more of like this stuff, like up here. So he kind of had crap, I call it crap, like all throughout his lungs. But do you see how this has that blurring that we talked about? So this is kind of like, you can't really see that angle. Let's go back to the normal one, the good normal one. See how pretty this is? I call it pretty. Nice and clear. You can see those sharp angles. And then you go to this kid's and it's like, wow, that looks like crap. What is that? Okay. So he had bilateral pleural effusion. Pleural effusion is basically fluid accumulation in the lining of the lung, as well as some patchy infiltrates. So infiltrates just means like fluid. Usually it means pneumonia up here in the upper lobes. So he had more of this white haziness up here. So his lungs were all kind of messed up. That CBC that we got showed leukocytosis. Leukocytosis means an elevated white blood cell count. Normal is usually under like 11.5 thousand. His was 14.4, so definitely elevated. Not the highest I've ever seen in someone with like pneumonia, but he was probably on the start of this infection, and it definitely like rose with time, and then it decreased after he got into the hospital. A left shift just means that usually there's a new infection. So that means there are new baby white blood cells. So they're called bands. So there's an elevation in his band. So that means the body is being stimulated to make new baby white blood cells because there's some sort of infection or inflammatory process going on. So anytime you see a left shift, that means that there is like a new acute inflammatory or infectious process in the body. So I saw this x-ray and I go, crap, that's not good. This kid actually walked in after hours. We have like 2 providers in after hours clinic where we'll see like patients at the very end of the day. Because we have like 20, 25 people in my clinic that'll staff and see sick call all day. But there are 2 people who will stay late to cover extra sick call hours so that the recruits have more time to be seen. So usually these people who come in, they don't really have anything urgent, but I wasn't really expecting to see this kid. And then I went and looked at the x-ray after he had those abnormal vitals and his lungs sounded crappy. And I knew there was not good stuff going on. So diagnosis for this, parapneumonic effusion is like the proper term. Basically, that's just a pneumonia, which is an infection in the lung, could be viral, bacterial. That's what pneumonia is, with adjacent, which means like right next to it, pleural effusions. Someone asked, what is the left shift referring to? Lab values towards the bands or like newer white blood. So a left shift is just like a term that is used to describe an increase in baby white blood cells. So if you say someone has leukocytosis with a left shift, so that means they have elevated white blood cells and their bands, their baby white blood cells, are elevated. So that's what that means. I hope that was helpful. Hanzabine is your name. Hope that helped. If it doesn't clarify, just let me know. So I directly admitted this patient. So this patient cannot be managed like as an outpatient. If you have a pneumonia and pleural effusion, no matter how young and healthy you are, you go to the hospital because that needs to be closely monitored and treated with IV antibiotics. So I direct admitted him to the hospital. That involves calling one of the attending internists, waiting for a bed, letting him know he's coming, giving him a quick summary of what's going on, giving a report, which is really scary when you're a new grad or like in school. That's like one of the scariest things is talking to a super senior like doctor on the phone. But you get a lot more comfortable as you go. But you know, I just said, this is Lieutenant Walter. I'm one of the PAs at so-and-so. I have 17-year-old male with cough for 5 days, his chest x-ray showed bilateral pleural effusion and patchy infiltrates, and you read off the vitals and they say good to go, like we'll get a bed ready for him. Easy as that, because they know this patient needs to be admitted. Sent him to the hospital by an ambulance. He did really well in the hospital. I didn't follow up with him, but I actually read his note because I wanted to make sure he was doing good. He got a bunch of IV antibiotics. I listed them there in case you're curious. He did improve fast. Sometimes people who have these big pleural effusions, they might need a thoracentesis. That's when they take a needle and they drain the fluid. But he did well with antibiotics right off the bat, so he didn't need that. So that's really good. He was only in the hospital for about a week or so, and then he left with oral antibiotics, transitioned to oral therapy, which you'll see very commonly. He saw another provider. I wasn't seeing him that day. I was in a different clinic that day, so I didn't see him as his follow-up, but he graduated boot camp, did well, and had no problems after that. So one of the cooler cases that I've seen, generally I see really young, healthy patients. So to see someone who's a little more like different of a sickness, more than just like a regular pneumonia, that was kind of cool, something different. And his chest x-ray findings gave me some good practice with reading chest x-rays because I didn't see a pleural effusion on a patient since I was on rotation. So that was cool. All right. Any questions about that case? Anything with chest x-rays, pleural effusion with pneumonia, brief? I know we're trying to stay kind of broad here. I'm not trying to go into too crazy detail, but any questions about the stuff we touched on? I'm going to scroll here and see if I missed anything as we were going. You guys did so good answering the questions as we went. Thank you for being involved. It'd be super awkward if I just had to talk to a screen and no one responded. And then I see like Mia, you asked like 2 good questions. I'll answer those at the end. I didn't forget about you. They're a little more general, so. Okay. So I think we're good with the cases. You guys don't seem to have any questions on those. So I hope I explained those well. Okay, so quick tips. Like I said, I didn't have to apply through CASPA. I took the SAT, ACT like you would for normal undergrad, but surprise, I had to take the GRE for the doctorate fellowship I applied for. And like, I'll tell you, if anyone took it yet, which I'm sure a lot of you have, it sucks. It really freaking sucked. Someone said, can you explain what a pleural effusion is one more time? So that's really just fluid in the lining that goes around the lung. So the pleura is like a thin tissue that surrounds the lung. So it's a fluid accumulation in that small pocket that surrounds the lung. So different than a pneumonia. Pneumonia is more like inside the lung. Pleural effusion is in the pleura. The pleura is the surrounding case, like sac around the lung. So Jonathan, I hope that helped. It's horrible. Yeah. So I hated the SAT, hated the ACT, hate standardized tests. Like, who doesn't hate them? That's why I applied to those 5-year programs, because I was like, I don't want to have to worry about taking another standardized test. It's also one of the reasons that I initially decided not to apply to med school, because I went to like a Barnes & Noble and I flipped through an MCAT book and I was like, yeah, I'm not doing this. And that's when I was like, I'm only applying to PA school. That wasn't the only reason, but that was like one of them. I was like, I don't want to have to worry about doing this. So I was really bummed when I found out I had to take the GRE again, or take it in the first place, because that fellowship moved to a doctorate program. So studied for like a couple weekends out of the month, focused mostly on the math because that's where I was super weak. I did like a Kaplan review course. It was like, gosh, like $300-400. That kind of sucked. I found something that's free that I actually really liked. And it's called Victor Prep Podcast. It's on like the podcast app. I have an iPhone, so I'm sure like Android has it too, or Samsung has it, but he just does vocabulary words. And I actually like got a couple of questions just from listening to that, maybe a few episodes. So I really liked using him because it's free and anyone can access it. So definitely recommend that for the GRE. If you like are looking for resources or like free resources, that's a really good option. Someone asked a question about the last case. They said, would you have treated the patient outpatient if only pneumonia without the pleural effusion? Yes. So we treat pneumonia as an outpatient all the time, especially young, healthy people like our recruits and our people in the military. A lot of times they're healthy otherwise. So if they have a fever and they are otherwise like their vitals are pretty much fine. If they have crappy lung sounds, I'm okay with that. And then they have just those patchy infiltrates, which means that there's some fluid inside the lung, but they're otherwise stable, totally 100% treat them as an outpatient. So you give them a Z-Pak, azithromycin, and then have them follow up in a couple of days or a week or so, make sure they're doing better. If they aren't, or if they start getting like shortness of breath, they come in and they have like a pulse ox of 92, they're still have a fever despite a week of antibiotics. That's a problem. So when they aren't responding to like your initial treatment, that's when it'd be time for like an inpatient admission. Or if they have other comorbidities, so they have like, cancer and they were being treated with chemotherapy, so they're immunosuppressed. If they have these other comorbidities that makes them like really sick, they would go to the hospital initially. But pneumonia with pleural effusion, they go to the hospital to be treated. So that's my little quick tidbit about the GRE, because I don't really have a whole lot to say about it. I took it twice. Sucked. I hate it so much. I will never take it again. I was so upset when I found out that I had to take it to apply for the fellowship, but I guess it was worth it because I got it in the end. So, like I said, I don't have a whole lot of experience with CASPA, but I do help a local PA program with like their interview process. So something that I heard a lot that they like to see, and other programs like to see from what I've heard from other like practicing PAs and PA mentors, is if you have a low science GPA, take a couple of science classes when you're in like your gap year to help boost it, and then also help prove to the program that like you're really committed, and that it means that that your science GPA was low and that you were trying to do things to fix it. I know it's like a financial contribution because tuition is not cheap, but if you're able to, definitely recommend that. Of course, I have to do a quick Navy plug. So if you are interested in like the military, not even just the Navy, I'm pretty sure all branches are the same. You have to be accepted to an accredited PA program in order to apply for the HPSP or HSCP scholarship. So after you have that letter in hand from an accepted school, contact a medical officer recruiter, and then you can start your application process. The application process is not easy. It takes a lot of time. So definitely recommend doing it before you start school. So if it's something that you are really interested in, you can do it while you have the few months, hopefully, before you start PA school, and then you don't have to worry about it while you're in class. I was in like my graduate level classes while doing my application. It sucked. I mean, it's doable, but it's hard. The podcast name, Hala, I think is Victor Prep. I have it on the PowerPoint, Victor Prep podcast under the GRE bullet. So you can look that up. I have a lot of people who direct message me questions about Navy stuff, so I'm always happy to answer those on Instagram, but I just wanted to put a quick blurb in it. Advice for PA school. This is really mostly for like while you're on rotation, so a little bit of a ways away for some of you, but rotations are great. They're so much better than like didactic year. Didactic year just freaking sucks, but it's like worth it in the end. When you're on rotations, if you have someone come in, like let's say someone coming in with like pleural effusion and pneumonia, and you're like, I don't really know anything about that. Like I can't spitball off like what you see on exam. What's the treatment? How do you know like to admit someone? Go home and read about it. That's like when I use that UpToDate that I was talking about. I would go home and read about that subject on an UpToDate article. And that way I could go to my preceptor the next day and like spitball an entire summary. That I found it made it much easier for me to like remember and recall information, even like in clinical practice years after clinical rotations. Because you can associate it with a patient in a certain case. I can say, oh yeah, my internal medicine rotation, I had that patient with like pericarditis and like we did this. So it makes it easier to associate it if you have something like to remember it with like a patient or like a certain case or a rotation. So that's like my biggest thing that I always tell PA students and my biggest like tidbit I have for clinical rotations. All right, so some questions here. Let's see. Alia Wallace said, what's the difference between HPSP and HSCP? So they're similar. Both have pretty much the same time commitment. They require you to do 3 years active duty service. So HPSP, you are not technically enlisted in the military whenever you did HPSP. So it does not count towards your retirement. HPSP covers your tuition and your books, and you get a small monthly stipend. It's like $1,500 to $2,000 or so to use for whatever the heck you want. HSCP, you are technically enlisted in the United States military. You're active duty. You will not be recalled to do anything. Your sole job is to finish PA school. You are paid as a senior enlisted, so an E6. You're paid at that rate, and you can use the money for whatever you want. So you're paid at a higher amount than that stipend in HPSP, but you can use it for like rent. You can use it to buy a car. You can use it for books. You can use it for tuition. I use mine for tuition, so I paid a majority of my master's tuition with the HSCP money that I had. That's the big difference. I also came in with 2 years of service, even though I hadn't really like been in the military yet, if that makes sense. You're considered active duty while you're into your 2 years of PA school. Depending on the year, it depends on which one is open. Sometimes there's both, sometimes there's only one. My year, they only had HSCP. So that's what I applied for and that's what I got. But that's the big differences between them. There's actually a really good website. If you go online and type in like Navy Physician Assistant, there's a NAPA page, NAPA, Naval Association of Physician Assistants, and there's a breakdown of HPSP and HSCP for PA school. So you can look that up too. That's what I usually send people whenever they direct message me, asking me about HPSP and HSCP. Those are really good resources for them. Okay, other question. Someone said, can a regular undergrad apply to PA programs in the military? No, so there's only one program in the military. It's called IPAP, IPAP, the Inter-Service Physician Assistant Program. So that is for current enlisted military members of any branch. They can apply for PA school through the military. So if you're a civilian, you're not eligible for IPAP. Someone said you work with NPs. I do. I actually work solely with NPs in my current department. My women's health department that I'm in now, I've been there for about 6 months. It is me and 3 NPs, and that's it. So very NP dominated. So I was the star of the show, and there was PA week 2 weeks ago. So they said, we love our single PA, and I'm the only PA in the whole clinic. So the other place I used to work at, there was a bunch of PAs. There was like 6, 7 of us, but the current and clinic that I'm in, I'm the only one. So I'm going to go back to some of the questions that people asked early on. They were a little more like general. Okay, someone said, is it more difficult or possible to practice as a PA in other countries outside of the military? No, so the military covers all aspects of like credentialing malpractice and that kind of stuff, and like collaborating physicians. So it actually makes it easy administratively because we're covered under like the government role when we go to like Italy or Spain to work on like a military base. Someone said, did you have to get patient care hours prior to applying to your program. So it wasn't required for Duquesne, the program that I went to. Some 5-year programs, actually pretty much all of them now, they require it. So, but I had patient care hours. I volunteered in an ER my last 3 years in high school. So I did have patient care hours because I knew I was interested in the medicine and I wanted to have it in my application, but it actually wasn't required the same way it is for CASPA. And CASPA has like way more requirements for patient care hours than what my program required. Mia asked, overall, if you feel comfortable answering, do you feel like the general autonomy that is said for a PA applies for your current role job or more than you expected? PAs in the military have awesome independence. PAs in the civilian world usually do too. It just kind of depends on the area you work in and like the position you work under. But for me, like, I don't really even have a supervising position, and I do on paper, but I go to like my PA peers if I have a question about something because I'm friends with them and I trust them because I worked with them like a lot, like more, not saying physicians don't know anything, they do. But I usually go to my PA coworkers before I go to the physicians. And I only go to them if I really have questions for the physician. So a lot of independence, a lot of like doing whatever you feel comfortable doing. If I ever have a question with something though, I will certainly go to one of the board certified docs we have in our clinic. They're great, very supportive of PAs. Someone said, Mia said, what is your most rewarding moment you have experienced as a PA just thus far? Probably, long story short, I had a patient, chronic belly pain for years before she came to the Navy. We did this whole workup. She went to see GI, didn't find anything. I tried to talk her into being treated for IBS, irritable bowel syndrome. We put her on a small dose of, it's called amitriptyline. It's a tricyclic antidepressant, but can also be used in a low dose to help treat irritable bowel. Changed her life. She said, no one's ever diagnosed me before. Everyone just pushed to the side, said it didn't matter. And she's like, I was running to the bathroom 9 times a day. I couldn't function. I hated my life. I was miserable. Like, this has like changed my life. That was like my first year as a PA, and she just made a big impact on me because she told me how appreciative she was and how much that meant to her. That's probably like my most rewarding moment because I had really good follow-up with her. In my current role, unfortunately now, a lot of the patients I see, I don't really see them again if they're getting worked up or something. So that's just because of the flow of like military medicine. We have a lot of different providers to see different people. Okay, more questions. Good job. Let's see. Would you say that PAs in the Navy are able to practice at the limit of their scope, more so in the private sector? Does this change with specialty? Yeah, so we're not limited really at all. Madeline asked about that. In the military, it's a big like see one, do one, teach one. So if you have it in your credentialing, you're allowed to do it, like you do it. There's no like, oh, you're just a PA. Like, we are very much so put on a pedestal in the military. We have a high respect. And in the civilian world, a lot of places are like that too. But one of my friends from PA school, she works in an ENT office, and they essentially use her as a medical assistant, which I think is like ridiculous. That really bothers me. They don't use PAs properly. They're essentially used as scribes. So that all depends on like the environment that you're in. So for me personally in the military, like, we are held at the same level as physicians. There's no like separation, which I think is like awesome. And that's what I really wanted. And so I'm super happy about that being in military medicine. How often do you do surgeries with the physician in your specialty? So I don't do any surgeries. I'm not a surgical PA. And active duty PAs, we really don't do surgery unless we complete one of the specialties, like the ortho general surgery. I also don't really like the OR, so I wouldn't want to do that anyway. I hate surgery. Someone said, Jenna, why did you choose to practice in the Navy and not in the regular world? So to put it simply, I have always respected service members. I wanted to be one of those people to provide them with like exceptional healthcare, because I think that no one deserves better healthcare than those who serve our country. And that's just a personal belief. And, you know, everyone goes into medicine because they want to make a difference. So, or most people go into medicine because they want to make a difference. So I wanted to make the difference. I wanted to impact service members. I wanted to help them and like provide them with really good healthcare. So that's the reason why I went into it. I wanted to be one of those select few who are able to give like these service members good healthcare. So that's really the reason why I went into it. Do you have to continue working for the Navy, or can you go back and work in the civilian world? So for me, my time commitment was 3 years. So I had to serve 3 years active duty Navy before I could get out if I wanted to. So I am past that. I've been working for about 4 years now. After the 3 years, I could decide to separate from the Navy and go work in the civilian world and whatever specialty I wanted. And I liked the Navy. There's more things I wanted to do in the Navy, so I decided to stay. So I signed on for a 4-year contract. They do retention bonuses for us, which was not the only reason I did it, but it was a nice incentive. So our pay is good. I can't complain at all about our pay. And the retention bonuses are really good for like helping to pay off loans, which is what I use a chunk of it for. Paying off my wedding, I use a lot of my bonus for. So the bonuses are really nice incentive. So after you continuously decide to stay in, they can offer bonuses after every contract. So that's really nice. So, but you're really only committed to 3 years. So if you don't like it, you can choose to get out. And I have friends who chose to do that. Madeline said, do you plan on staying in the Navy longer than the 3-year commitment? What do you want to accomplish in the Navy before getting back to civilian life? So yes, I plan on staying in for the foreseeable future. I'm definitely on for at least 4 more years. The time commitment for completing the DUINS fellowship, that's the emergency medicine fellowship that I applied for, that is 3.5-year time commitment because it's a doctorate level program. So the Navy is paying me to get my doctorate, which is like super awesome. There's like nothing better than that, than getting paid to get a further education. So I'm very excited about that. I also plan on teaching like when I get out of the military, whether that be after the 20 years or after retirement. So I think the doctor will really help with that. And I want to deploy, I want to work with the Marines. I want to deploy with the Marines. As an emergency medicine PA, we're actually put into billets. Billets are just like jobs with the Navy. So emergency medicine PA billet a lot of times is actually a emergency medicine attending physician billet. So these EMPAs are in the same spot as an emergency medicine physician. So that's like awesome to me. It means the Navy trusts the training they gave us. A lot of times we're in emergency rooms across the country. So like Portsmouth, San Diego, Camp Lejeune, these like bigger Navy hospitals. So we're in an ER there, or we're with the Marines and we're the ones going overseas with them for deployments to, the Middle East, Afghanistan, Kandahar, and caring for these Marines if they are injured, stabilizing them to get them to like a higher echelon of care. So that was a really long response, Madeline. But yeah, so I want more education. I want more training. I want to deploy. I want like more of an operational experience because I've been in a clinic for 4 years. So I feel like I haven't really gotten like a true like feel of like actual military medicine yet. And I want that. So that's why I joined. Vincent said, once you finish ODS, can you become stationed anywhere, or do you have to go to one of the larger Navy hospitals like Balboa or Bethesda? Do you know much about going Greenside as a PA? So first part of the question, so we don't have to go to one of the big Navy hospitals. There's actually billets for PAs all over. So Washington State, San Diego, Texas, Camp Lejeune, Norfolk, Portsmouth, Sigonella, Japan, like we can go carriers, we can go all over. Nurses, they go to one of the big 3 usually. So that's your like Walter Reed, around DC, San Diego, or Portsmouth, Virginia. But PAs, we don't do that. We can go anywhere. So they try to take your input into account with what you want. But it's all about what the Navy needs. So you can rate places all you want, but ultimately it's wherever you're needed. That's kind of how it is. So, and then do you know much about going Greenside as a PA? So not personally, I can't speak from personal experience. I have a lot of friends who are PAs who have gone Greenside, or they've come from Greenside, or Corm and I work with Greenside. So I feel like I know a good bit from them, but I can't speak from personal experience. So really, Greenside, you're the medical officer for a bunch of Marines. That's what Greenside means for anyone who doesn't know. So Greenside is your medical officer attached to usually like a battalion, and you are their like primary care and their medical support for them for training exercises, for if they deploy, whenever they're on base, like in the States. So that's a big place for PAs because we're so mobile. So that's a big thing that we can do as PAs is go Greenside, work with the Marines. Wendy asked, how was life like in the Navy as someone who doesn't know anything about it? What's life like? So I think Wendy, are you asking like, what is life like? I think it's what you're asking. So for me, it's pretty normal. Like I said, I work in a normal, like Monday through Friday clinic. I work the weekends every once in a while, but I haven't had that true like military experience yet. So when I get deployed, it'll be a little different. So I've been here with my husband for the last 4 years. So it's been very like stable. I've been very fortunate, very luckily, and I'm thankful for that. But I'm looking forward to like new opportunities, definitely. Madeline said she's interested in the HSC PHPSP program. Awesome. Feel free to message me if you have any other questions. And she asked, how was married life being in the Navy? So right now it's been easy. I planned my wedding from being a couple states away in Pennsylvania. My mom helped me a lot with it. But it's been pretty stable. You know, we both work our jobs. We come home, we talk about them. When I'm away, it'll definitely be an adjustment, but he's understanding. He understands this is what I want to do. We actually met at a bar in Pittsburgh when I was still in school. And the first thing I told him was that I was going to the Navy after graduation. So if that wasn't for him, then we should just like end it right there. And it was a dream of mine for a very long time. So I was very excited about it. I actually met him shortly after I was selected for the scholarship. So he said, I'll follow you anywhere. And he ended up with me in Chicago. He was bummed that we didn't get Texas or somewhere warmer, but it is what it is. So we'll see. All right. I think I got the questions that you guys asked. Pre-PAPals that did you guys see any questions that I missed or anything?
No, you did so good. You caught all of them. Literally every single question. We have no idea how you did that.
Oh.
Nobody,
Oh, wow.
Nobody's ever been able to do that before. So I'm like crossing them
Really?
off the list as you go. So very impressive.
Oh, I guess. Oh, I'm a good multitasker, I guess.
Yeah,
Thank
you're
you.
amazing. That was incredible. But yeah,
all right, awesome. That went longer than I thought. So I'm sorry, guys.
Oh, no, you're fine.
Yeah, no problem, guys. Thank you so much for having me. You guys are awesome. I think it's so great that you guys are doing this for Pre-PAs. I love your forum, everything about it. So stay motivated to keep doing what you're doing. You guys are awesome.
That's, the biggest compliment we could get from you. Thank you so much. On behalf of the audience, I'm sure everybody loved that presentation. Sure. It was informative. It made me go through a range of emotions. When you were talking about the vaginal test, I was like, oh my God, no. Like, you know, you're talking about x-rays. I learned so much. It was really, really great. It was awesome.
Good. Awesome. I'm glad.
But yeah, did you want to do a few more questions or?
Yeah, there are more questions. Did I miss some?
No, I think everybody's done. Just asking if you want to do anything else, but yeah, that was amazing. Really
No, sorry. I forgot to hit through the slides. This was my question slide. This was just pictures from trainings I've been to, guys. Sorry, but I forgot to show them, but that's them now. So, but if any other questions, feel free to message me. I'm tagged on their thing, so you can find me, direct message me anytime. I try to answer them every few days. So happy to answer any other questions about anything else.
All right. Thank you so much. We really appreciate it. Yeah, like she said, she is on our Instagram. We will share her as much as possible because we do definitely love hearing from her. She has some great information on her Instagram page. If you guys will please follow her. We really appreciate this. But yeah, thank you so much. We appreciate it.
Yeah, no problem, guys.
Thank you for your service. Really appreciate that. You're awesome.
Oh, thank you so much, guys. I appreciate that.
Yeah, but yeah, guys, we're going to be putting that link up for the quiz shortly here, and you will have 1 hour from the time that we post it. We'll put it up on Instagram and in the chat right here. All right. Thank you so much, Katie.
Thank you so much.
Yeah, no problem, guys. Thanks for having me.
Absolutely. Take care.
Bye.